those of you who aren't familiar with me or don't know me, my name is Mei Kwong. I'm the Executive Director at the Center for Connected Health Policy. Next slide. And I'm an attorney by training, so I always have to start off with disclaimers, but also I get federal funding. They want me to start off with disclaimers. So any information I provide today is not to be considered legal advice. It's strictly for informational purposes. If you want to form a legal opinion, please consult with legal counsel. And if I happen to mention a company or show a picture of a product or something like that, know that neither I nor CCHP has any type of relevant financial interest, arrangement, relationship, or affiliation with such a company. Next slide, please. A bit of background about CCHP. We were established in 2009 actually to be a California telehealth policy organization as the program underneath the Public Health Institute. An opportunity to become the federally designated National Telehealth Policy Resource Center became available in 2012. It's a grant through HRSA, and CCHP applied for that and we got it, and we've been serving at capacity ever since. What that means is we received this federal funding to provide technical assistance. Technically, when we got the grant, they said, we will provide technical telehealth policy assistance to the other telehealth resource centers who are funded underneath this program. So our main audience was actually the telehealth resource centers. But when we got the grant, they were actually pretty vague about the parameters on what they wanted the policy center to do. So CCHP kind of crafted what we saw was the need out in the telehealth community. And that also meant expanding the scope of who we would serve or who would be able to like call CCHP and ask questions around telehealth policy. So now we've expanded it to basically anybody who may have a question on telehealth policy can reach out to CCHP and we'll try our best to help you. HRSA is still focused on us having the telehealth resource centers as a main audience, but also providers in rural and underserved areas, different organizations that serves those groups as kind of more the main audience, but they don't really object to us like, helping other folks too if they have questions. And during that pandemic, that audience definitely did grow. And in one of the places it did grow where we were getting direct calls from patients and consumers who for the first time during the pandemic were suddenly introduced to telehealth and they were like, what is it? How do I go about getting in? Where do I start? CCHP also works with a variety of other funders and partners such as Cchp on like more specific projects or projects related to telehealth or connected health. We act as the administrator of the National Consortium of Telehealth Resource Centers. And what that means is a couple of years ago, the telehealth resource centers were all funded individually through these grants from HRSA, but we realized that there was a lot of duplication of work going among programs such as, one telehealth resource center would create like a fact sheet on HIPAA, then another one would create. And it's like, that's a waste of resources. Why don't we collaborate together, find out what are these common types of tools and materials that we can work on together that can span multiple regions or nationally and like save on some of those resources. So we funded the National Consortium to do that and work on these collaborative projects. CCHP was selected to act as an administrator of that group, which basically means I act as a point of contact for people. So that way you don't have to reach out to all 14 of us, you can just reach out to CCHP and I make sure everybody is in the loop on like that, what's being requested. And also CCHP acts as a convener for a group in California called the California Telehealth Policy Coalition. So this is actually one of the first sort of statewide coalitions focused specifically on telehealth policy, but I've noticed during the pandemic that more and more have appeared in different states. So we've been running this group since 2011, and it has like over 150 statewide and national organizations that are interested in advancing telehealth policy in the state. Next slide. So I mentioned earlier that I'm going to cover both federal and state. Now, federal, a lot of that is related to Medicare, and that may not exactly impact you or impact your program or impact the population that you service. The reason I'm going to spend a lot of time on that, though, is the influence that federal policy, especially in Medicare, has on state policy and what goes on in Medicaid, what goes on in like legislation that the state may pass. And I'm already starting to see little bits of influence coming through on what they did on the federal level and like pieces of legislation introduced in the state. So it is important to sort of track what goes on in federal, even if you're thinking like Medicare doesn't impact me, I'm Medicaid. It's because a lot of that gets reflected on the state level as well too. Also, commercial payers sometimes take their cues from what goes on in Medicare because it's kind of easy. There's an established telehealth policy. I'm just going to copy what Medicare does. And like, that's probably like a good way of like, setting up my policy here in my commercial health plan. So it's very important to understand what's going on the federal level, just because of the influence it has in like other jurisdiction. What you have in front of you. Oh, and I also want to say, this is going to be a little bit of a long presentation, so feel free to interrupt me if you have a question, or if I'm going too fast, or if I say like an acronym or something that is confusing to you. I get like steeped in the lingo sometimes, and I sometimes forget like not everybody is like living and breathing and eating this telehealth policy. So if I like say an acronym or use a term you're not familiar with, feel free to just like verbally interrupt me. We're small enough of a group like that that's perfectly fine. What you have in front of you is sort of your 100,000-foot level overview of what happened on the federal and state level as far as telehealth policy changes during COVID. Now, for the most part, almost all of these were, when they were introduced, were temporary changes of like, we're just going to allow this for a period of time. And that period of time like varied depending on like who you're talking about. They said like, oh, as long as the federal public health emergency is in place, or if you're a state, they said as long as the state of emergency that we declare is in place, or they may have actually even put like an end date, like through, June of 2020 or something like that. And then some states extended it, or if it was tied to like the federal public health emergency, it just went on, extended it. But as you can see, there are very close or similar areas, issue areas that the policy changes, temporary changes touched upon, such as location of the patient, the modality that's used, the services that are covered, the types of providers who provide the services. And that's because a lot of established telehealth policy before the pandemic revolved around reimbursement. What was paid, what was covered, depending on the program that you're in, whether it's Medicaid or Medicare. And those policies usually had certain common elements on them. And I'll dive into that a little bit deeper. But you can also see that there were other sort of policy issues that were in the jurisdiction of like whatever federal or state that you were talking about, such as on the federal level, prescribing of controlled substances. So you see a little bullet point there about the DEA, or like HIPAA, and then on the state level, licensure, on like, what they were doing around licensure. So there were still some issues that were solely like in the jurisdictions of either states or on the federal level. Next slide. Now, federal policies, next slide. We'll tackle that first. Now, federal policy, to understand telehealth policy on the federal level, the majority of that is in Medicare. Now, this is policy that's established. It says telehealth specifically into it. It specifically applies to telehealth. It is really revolving a lot of it around Medicare. There are other policies that sometimes mention telehealth, such as I mentioned earlier, prescribing controlled substances, and other policies that impact telehealth that don't necessarily mention telehealth or is specific to telehealth, such as HIPAA. HIPAA is more widespread, but there's nothing in HIPAA that specifically referenced telehealth. So those policies on the federal level do impact telehealth, but really where you get your sort of main grouping of federal policy around telehealth is in Medicare. And to understand Medicare policy, Medicare has two approaches to technology-based services and what they cover. They have one category that they call telehealth. This is a category of policies that are specifically labeled telehealth, and a lot of this is embedded in federal statute, where they have a lot of limitations of say, it needs to take place in a certain geographic area, it needs to be a certain provider, it's only these types of services that are going to reimburse, etc. And that's their telehealth policy. So CMS, the administrator of Medicare, is very limited in what they can do because a lot of that is embedded in federal law. They've got to wait to Congress to act. They have some areas where they have some leeway, but for the most part, a lot of the major barriers, a lot of what we saw the waivers for, are embedded in federal law, so Congress needs to act. Then Medicare has another category called communications technology-based services, and these are services that use telehealth technology to deliver those services, but CMS does not regard them as telehealth. It's this other category. Now, what's the difference? How do they make that distinction? So really roughly, they say telehealth is a replacement for an in-person visit. So you go in for like a regular office visit with your provider, you can do that via telehealth. There's a one-to-one replacement. That is telehealth. Communications technology-based services are services that normally don't happen in person, but because technology is so advanced right now, we can suddenly provide those. So we don't typically cover these because we've never had to before. They didn't really take place in person. So for example, remote patient monitoring. I'm a patient with hypertension. My provider wants to monitor me for like a 5-day period and take 3 blood pressure readings in a day. So I'm not going into like a blood pressure clinic every day, 3 times a day to like get that done in person. But I now have like technology where I'm doing it at home and the readings are being sent to the provider. That's remote patient monitoring technology. That would be covered under communications technology-based services. So that's the distinction they make. Now, why do they have these 2 categories? Well, I mentioned earlier that telehealth is restricted a lot, or its policy is shaped a lot by what's in federal law. Communications technology-based service is essentially something that CMS made up administratively. So those limitations in federal law don't apply to communications technology-based services. CMS will come up with their own limitations, but they're not facing the telehealth limitations. I'm spending a lot of time on this is because it got very confusing during the pandemic, because some people were doing communications technology-based services, but they thought they were doing telehealth. And then like some of the policies were very confusing to them, say like, why am I not getting paid what I thought I would get paid? It's like, oh, because you're billing it as communications technology-based services. So that's why. It gets more confusing when you go down to the state level, because the state levels may take the same approach in that they're separated out into these 2 categories, or some states have adopted the communications technology-based services, some of those services underneath their telehealth policies, or some of them have adopted them underneath their telehealth policies, but they treat them as communications technology-based services. So it gets even like more confusing when you get down to the state level. So it's kind of hard to pick through, and you have to like really study, like, I'm now in California and they do X, but I've now moved to Pennsylvania and they do Y. So that like adds another layer of complexity to all this. Next slide. Now, I said earlier that a lot of established telehealth policy was focused around reimbursement and coverage, like what gets paid for, what gets covered. And a lot of those policies usually have 4 common elements within them: service, location, provider, and modality. So what service is being provided, where the patient's located at the time of the service, what modality is used to deliver the service, and who's that provider delivering the services. So when you look at a lot of the established telehealth policy around reimbursement, it touches upon all or some or at least one of these elements usually. So for example, you may have a Medicaid program that says, we'll only reimburse for behavioral and mental health services, so services covered, when the patient's located in a clinic or a doctor's office location of the patient, when it's being provided via live video, the modality is being used, and when it's being provided by a psychiatrist, the provider who is providing the services. And that's how they limit the coverage of telehealth. They may say like, oh, we're only provide for these 5 services via live video when the patient is at home or in the clinic, and only by this list of like limited providers. Now, going into the pandemic, Medicare had one of the most restrictive policies. They had like practically a limitation on all of these in some way. So that's why when the pandemic started, you saw so much action on Medicare's side of things where telehealth policy was concerned, why there were so many waivers. It's because they were so far behind. They were kind of operating in like 2006, 2010 type of like policy, because that's kind of like the last time they made a major update. So they had to make adjustments for like practically all 4 of these categories. And now not all 4 of these categories are restricted by federal law, but a lot of them are. The provider, the type of provider provides the services, the location of the patient. The modality one, there's a debate on that. I think CMS has a lot more flexibility. For a while there, they like argued with me that they didn't, kind of changed their tune in 2021. I'll get to that in a second. And the service is like, what services covered is fully underneath CMS's control. But the big one, a provider and location, when eligible provider and location, those are the 2 big barriers on Medicare. I will say that on the state level, the location, as far as like geographic location, even before the pandemic, the states were limiting things like that. they weren't eliminating things like site. So, going into the pandemic, a lot of places didn't allow the home to be an eligible site, but at least for geographically, they were not really following what the feds were doing on the state level. And the provider limitations, having a specific list of providers who can only provide it, that was kind of a bit of a toss-up. There were some states that did have specific lists and other states that were like, as long as they're Medicaid eligible and they're acting in their scope of practice, we're fine. But that was like a little bit, again, going into the pandemic, some states were kind of half and half is like where they were. Next slide. Now, the way to change things on the federal level, and I kind of alluded to this, are two ways. You can either do a law change, which if literally act of Congress needs to happen to change the policy, or you can do something administratively. Now, Congress, I can tell you so far, they have not really acted on anything during the pandemic of making any temporary waiver permanent. So CMS has done a few things administratively. And I said earlier, they're kind of limited in what they can do. Going into the pandemic, I had argued with them saying, like, you're not taking full advantage of what you can do administratively for the past couple of years. Starting in 2021, they started being a little bit more creative than what they had been in previous years. So the way they would make a change administratively on telehealth policy is usually through the physician fee schedule. For those who are not familiar with it, the physician fee schedule is basically a regulatory process they use for deciding like their Medicare policies that they're going to change for the following year. So they will introduce it in the previous year. So for 2022, they introduced it in the summer of 2021, usually in July. And he said, these are the changes we're proposing to Medicare that will go into effect in 2022. Then they have like, I think it's 60-day comment period where the public can comment on their proposals. And then they finalize things like around like November, sometimes early December, and said like, okay, these are the final policies that will go in effect January 1st of 2022, unless stated otherwise. So that's typically their process. And what they did in 2021 was they took advantage of some of the administrative flexibilities that I and several other groups have been arguing that they had. And what those flexibilities were doing a redefinition of things as to like what was a visit and what was a telecommunication system. And so that meant like what type of modality could be used. So they went ahead and like got a little more creative. Next slide. And what that meant was they focused in on mental health. So on mental health, there was one thing that they had to do because this was something Congress directed them back in December of 2020. So they finally did the regulations for it. And it revolved around mental health. And it basically eliminated the geographic restriction, allowed the home to be a place where you can receive services via telehealth. Before this act, which was passed in December 2020, the Consolidated Appropriations Act, there were like a limited set of services you can receive in the home if you weren't in a public health emergency. And these services were end-stage renal disease services and mental health services, but you had to have a diagnosis of a co-occurring substance use disorder. So a very sort of narrow band of windows of like stuff that you can receive at home without the geographic limitations if you're using telehealth. The Consolidated Appropriation Act for behavioral mental health services widened that window and said like, okay, you didn't have to have like a co-occurring diagnosis or substance use disorder. You can receive mental and behavioral health services in the home. However, certain conditions were going to apply. And one of the big ones was you needed to have an in-person visit with that telehealth provider at least 6 months prior to receiving telehealth visits. So they opened up a window, but they kind of narrowed it again. So this was CMS in the physician fee schedule applying like a policy that they had to because Congress passed this bill. But what they did was, this was for expanding those mental health services. We think there's going to be a big need. There continues to be a big need for mental health services. So we're going to expand that even further. And we're going to say that you can allow audio only to provide the services, again, if certain conditions are met. And those conditions were very similar to what was required in the Consolidated Appropriations Act. And you can provide mental health services through audio only. Now, the way they were able to do this was because in federal law, when you talk about telehealth in the Medicare program, they said it's delivered via a telecommunication system. telecommunication system is not defined anywhere in federal statute. So that was a little bit of leeway that CMS had administratively to like give it a different definition. And what they said was, okay, our definition of telecommunication system will include audio only if you're providing a mental health visit. So it doesn't mean that you can use audio only if you're doing like a primary care visit, or if you're doing a dermatological visit or something like that, or a cardiology visit. But if you're providing mental health services, if you meet these other conditions, you can do it via audio only and get paid for it underneath the Medicare program. What they also did was they said, we're going to redefine what a mental health visit means for FQHCs and RHCs, so federally qualified health centers and rural health clinics. Now, for those of you who are not familiar, I mentioned earlier that underneath federal law in the Medicare program, they have a specific list of providers who are eligible to provide services in Medicare and get reimbursed. FQHCs and RHCs are not on that list. So that would require an act of Congress to make them telehealth providers. But you're asking me, so how did they do this then with CMS, allowing FQHCs and RHCs to use telehealth to provide mental health visits? They redefined what a mental health visit meant for these organizations. So what that means is that these FQHCs and RHCs are not considered telehealth providers. They are simply just providing a mental health visit as it's defined for them. But right now, the definition of mental health visit also includes being able to use live video or audio only to provide that visit. So it's a bit of, I don't want to say trickery, but it's a bit of, sort of policy sort of gymnastics here in trying to expand it within how they can expand it, within the powers that they have to do this. So they managed to expand it a bit for mental health visits, but they tacked on a lot of conditions there, such as you got to have a 6-month visit with the in person with the telehealth provider. Now they made all these other exceptions to it too, such as, unless the provider thinks it's going to disrupt services, then like maybe you can like extend it out or something. So that has been like interesting to like trying to sort through all that, but they have expanded things a bit. I'm spending so much time on this is because this is like one area where I'm starting to see like some of this policy possibly being duplicated on the state level as well too. So for me, that raises a little bit of concern because this is so complicated in the way that they did it, that it's probably going to not really expand services as much as I think they were hoping to. But I understand their concern of like, trying to still be responsible, but it's like, I'm not sure how useful this is going to be if you like tack on all these conditions to it. Next slide. So the other things that they did were, and this is like fully underneath CMS's control, is like what services are going to be covered. And the way CMS does it, and actually way quite a few state programs do it as well too, Medicaid programs, is they do it specifically by services. And what they do, what I mean by that is they cite the specific codes, cite the specific CPT code of like, this code is eligible to be provided via services and we'll cover it. So CMS has back in previous years, in 2020 for the 2021 policies, they added some of the temporary codes on the public health emergency list for telehealth onto the permanent category. So with the public health emergency had ended, there were about 9 codes that would still remain from like about the 200 that they allowed on a temporary basis. What they also did was they created a third sort of bucket for services of saying like, some of those codes on the temporary list, we think they have merit of possibly keeping around even the public health emergencies declared over, but we don't have enough evidence for it yet to feel comfortable doing that. So we're going to put them in a bucket called category 3. So they will stick around until the end of 2023. So let's say if the public health emergency was declared over in December 2022, these other services will stick around for an additional year just for them to gather evidence. So if you're on that temporary telehealth COVID list, if those codes are not on the permanent list already or not in this category temporary list, once the public health emergency is declared over, those services are no longer available to be covered. So that was another thing they did underneath the physician fee schedule. Next slide. Now, I talked about those communications technology-based services, and this is where we're getting into that category. So these are services that use telehealth technologies that they will cover underneath Medicare, but they're not considered telehealth. So they don't have those telehealth limitations of like only these certain providers can do it. It can only take place in these types of geographic areas, da, 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 da. They got their other limitations, but they don't necessarily face those. So they created a new category called remote therapeutic monitoring. These next couple of slides, very text heavy, dense. So I'm not gonna like go over every single detail. You can get a copy of the slides if you want them. But basically they created another category of services that would use remote patient monitoring types of technology to provide these services. And they said that we will cover them in 2022. Next slide. And then these are like additional sort of other codes that fall underneath the communications technology-based services there. So they finalized certain codes that they had temporarily allowed, such as permanent adoption of the longer virtual check-in code, and then some codes for chronic care management and principal care management. There's a lot around those remote patient monitoring types of services. Next slide. And then these are just a bunch of other miscellaneous changes that they made related to telehealth. I'm not going to spend a lot of time on that. So next slide. A couple other things to keep in mind on what's going on at the federal level. So you probably hear a lot of this when you talk about telehealth policy is like the concern from policymakers over fraud. How much fraud is in there? And actually what we found, at least with Medicare, to this point, is that the Office of Inspector General said, we actually have not found a lot of telehealth fraud, if really anything. What we found is telemarketing fraud, essentially. So it's not people who are submitting false claims for telehealth services. They're submitting false claims or ordering like durable medical equipment, but not necessarily like for that telehealth visit. So they did say that we haven't examined all the pandemic type of claims yet. So we can't say for certain that's not happening at all, but so far we haven't found anything. However, they will have 2 reports coming out this year in that they are looking at, what are some of the integrity risk and also looking at the services that took place during COVID-19. So those are some things to be aware of. Next slide. There are a series of bills that have been introduced. So there's like about over 200 federal bills that have telehealth in there that have been introduced. And some of them, quite a few of them really look at like the temporary waivers and what to make permanent. And some are doing other things such as, doing pilots or maybe making, looking at some other aspects of things. I actually today just got off the phone with a congressional member who's looking at telehealth in the homeless population. So I was like, oh, okay, so maybe there'll be like another bill related to that. So there's like specific areas that they're lawmakers might be particularly interested in. So there's so many of these that are out there. Do I think any of them will pass? No. What I think will happen is that there may be an interest in taking elements of these things and putting them in a large bill. And that's actually sort of where the discussion has been. Although lately they said discussion on like extending the telehealth waivers has broken down on the Hill. So who knows? But I think if it's anything's going to pass, I'll probably put it in a larger bill as opposed to like having one of these standalone telehealth bills pass. The other interesting that's going on is around HIPAA. Now, I mentioned earlier that HIPAA has nothing specific to telehealth in it. It's because HIPAA is old. It hasn't really been updated in a while. So, but there was an executive order that was signed last December saying that, the Secretary of Health would develop guidance for entities regulated pursuant to HIPAA on providing telehealth and compliance with HIPAA rules to improve patient experience convenience following the end of the public health emergency. So that was interesting to see. That was a directive to the secretary to really start looking at this. So we may start seeing maybe something coming out specific to telehealth and HIPAA this year based upon this executive order. So that was just something to put on your radar. Next slide.
And I was just going to flag, May, there's a question in the chat from Michelle of, are healthcare providers required to record telehealth services?
No. There is no requirement anywhere, and a couple of things. So there are some Medicaid programs that explicitly prohibit that, saying that you're not supposed to do that, and they have that in their manuals. I am not giving you legal advice, but I would say that some attorneys might suggest that that may not be like the best idea of like recording things. You also have to keep in mind storage space. I mean, if you're recording your telehealth interaction, where are you going to store that? All of those, especially you have a lot of those, that's going to take up a lot of space as well too. But I can tell you there are some jurisdictions in Medicaid programs, there's at least like 2 to 5 of them where they explicitly prohibit it, and they say in their Medicaid manuals, you will not record these sessions. So, but there's no requirement anywhere that I've seen that says that you must. Medicaid reimbursement for service modality. So on the Medicaid side, under their fee-for-service policies, permanent policies now, we're not talking what they may have done for COVID, but permanent policies, every state reimburses for some type of live video. Usually it's around mental behavioral health. That's the most common sort of like area you see, like a policy for reimbursement in Medicaid. Store and forward and remote patient monitoring, the other modalities, it's a less popular. What has been new though is that last one, audio only. Prior to the pandemic, audio only really was not considered underneath the telehealth umbrella by a lot of jurisdictions. In fact, it was usually explicitly excluded. They would say things of like telehealth means X, Y, and Z. What it does not mean is email, fax, and phone. But that definitely changed during the pandemic in allowing audio only to be used, because to the credit, policymakers recognize that not everybody's going to have access to live video. So how are you going to get services to people? And audio only was kind of really the only other way, short of having them come in person, which may not have been like the best idea. So what we're starting to see is that states are starting to adopt policies that will allow audio only, very similar to Medicare, like maybe in a limited fashion. And a lot of times it's usually around mental and behavioral health. Next slide. Private payers laws are the other things that usually is in state jurisdictions. This is telling health plans what they must do around telehealth. So the majority of states do have some type of telehealth private payer law. They range from a state saying like, the health plan, you can cover telehealth if you want to, all the way to a state that says health plan, you shall cover telehealth delivered services the same way you would have had it been in person. And by the way, you'll pay the provider the same amount you would have in person. And then everybody else kind of falls between the two extremes. What we're starting to see more of during the pandemic are states changing that parity requirement. So beforehand, most of the states with the private payer laws usually had requirement a parity of coverage, just saying like, you need to cover it the same, you need to cover it if you would have covered it if had it been delivered in services, but they didn't necessarily say you will need to pay the same amount had it been done in person. If it's now done by telehealth, that's been kind of changing over like the last year or so, and states were passing that more, either they were silent on it or they were being very explicit in saying that you now need to like pay the same amount regardless if it was in person or telehealth. So that is like another change that we're seeing as a result of the pandemic, I believe. Next slide. So in 2021, what we saw were 47 states passing 201 bills related to telehealth. Again, a lot of them were around that private payer reimbursement or Medicaid. Licensure, big issue. We haven't really talked about that, but that's like after reimbursement, one of the major areas of calls that we get here at CCHP is like licensure, because some states relaxed their licensure laws. Essentially, before the pandemic, the rule was you need to be licensed in the state that the patient was in. So if you were in a different state, you better have a license for the state that that patient's in, or otherwise you're violating the state law there. There were some exceptions, they were very narrow, but for the most part it was, you need to get a license. So there was relaxation of that during the pandemic of like, okay, well, during the pandemic, as long as you're in good standing in your state, it's fine. But now those are like going away. So the question is like, how are states moving towards that? And some of them have, and they've done it in one or two ways. They've done it either through compacts, the licensure compact that they've joined, where depending on how that compact is set up, you can have one license, you're allowed to practice in multiple states, or you are allowed to go through a process that's easier to get a license in another compact member state. But two states, Arizona and Florida, have done something interesting. They created a registry that you can get on, and you would not have to get a license in that state. Now, I don't know how onerous it is to like get on that registry, if it's like a complicated process or something, but it is like a different tack than what we've been seeing of like, you either need to get a full license or you're going through this compact route. Other things that we're starting to see are like on policies around online prescribing and how telehealth works that, and then specific language that allows telehealth for certain providers. Before the pandemic, a lot of states, they either limited and said like, oh, only these licensed providers can provide telehealth and get paid for it under commercial payers or by Medicaid. Now there's like more specific language saying like really meant to like, include more of these providers type of language. Next slide. So here are like a couple examples that you can see of like different areas of like different policies passed where they are struggling with right now. And this is the same thing on the federal level, is like what to do when the public health emergency is over. Some states have already like settled on the policy. They've adopted things either through legislation or their Medicaid policy process. Others have done what I call the kick the can down the road decision, where they've like said, we're going to extend it out to the end of 2023 and then make a decision then on what we're going to do with the telehealth policy. That'll give us more time to study it, gather data, et cetera, et cetera. So you might see that crop up too. Maryland has done that. California has done it until like the end of this year because they're working on policies now. It may be something we see replicated on the federal level. That had been the talk until, talks broke down, as they said like a couple of days ago, where they were saying like maybe we'll keep around the temporary policies for another 2 years. So that is possibly like a route that they can take on the federal level or on the state in some of the other states as well. And I think that's it. Brittany, I think the next slide is just sort of contact information for us.